We're doing a lot of work in negotiating case rates and bundles for our clients pretty much on a one-off basis, and recognizing that that wasn't necessarily our day job as consultants. We were looking for different avenues through which we could align our clients with the marketplace, especially the marketplace that we could see was evolving toward cash pay transactions. And we were introduced to Corb by a friend of ours that was involved with Levitt Risk Partners, and gave us the insight to, what the process looks like, the technology, and what you can actually achieve through the cash pay process. We've implemented Corb in our groups. We don't do a lot of retail consulting, but the groups that we do work with, we've got the cash pay and engaged in there. And, it works very, very well, and it does achieve a lot of cost reduction, but more importantly, and I'm not going to talk a lot and let Corb take the stage, but more importantly, a very high level of consumer satisfaction, because when you intercept these patients at the earliest point possible and make sure that they have the proper incentives, that if they go down the cash pay pathway, that their out of pocket is either zero or very minimal, or they can basically earn incentives that will offset their out of pocket costs. And, the key to it is interception. We do a lot of work in the primary care in the capitated model environment, and aligning cash pay into capitated primary care works extremely well because of the fact that the primary care doctor controls the referral. And so that's been something that we're beginning to move more aggressively in that pathway. So I'm not going to take up a lot of time, and I'll introduce to Corb and let him go from here.
Thanks, Scott. Take it away, Corb.
All right. Thank you very much, Daryl, for inviting us. And thank you, Scott, for the introduction. I just want to quickly introduce my team. I'm joined by my co-founder, Dr. Lisa Benke, who really is one of the real foremost leaders in kind of cash payment, and Nicole Wishi, who's responsible for our operations. So that's who's with me today. In the interest of time, I'll jump into the presentation. We'll keep it pretty quick and reserve as much time as possible for questions. So if folks would just let me know when they see my screen.
You're good. Okay,
great. So Asserta Health is all about delivering an ability to pay cash for healthcare. Our team has decades of experience on all sides of healthcare payment. We work for both large payers and large providers, and our experience working in the weeds of healthcare payment convinced us that you can't make healthcare more affordable without fundamentally changing the way we pay for it. The standard claims-based third-party reimbursement model, it's even hard to say, is a significant barrier to industry efficiency, to innovation, to consumerism, and consumer experience, and therefore affordability. So we created Asserta Health to deliver a more efficient, retail-like, immediate cash payment model, and developed a proprietary system that we call MediCash that enables immediate cash payment for any healthcare service. Our value proposition for employers is to improve affordability while simultaneously improving member and provider experience. To give you an idea of how MediCash impacts the member experience, let me tell you the true story of Janet. So Janet had both of her knees replaced. She first had her left knee replaced using a traditional health plan, and it was a real nightmare. She had no way to evaluate quality or her surgery. She was worried about whether she could even afford the procedure. And after her surgery, the barrage of confusing bills and collection notices took months to resolve. It cost her nearly $4,000, cost her plan almost $31,000. I'd now like to contrast this with when Janet had her right knee replaced the next year using MediCash. So when her doctor told her she needed to have her right knee replaced, she really dreaded going through the process all over again. She called Asserta Health because she heard it would save her money. The concierge service that we provide asked her questions to understand her medical need, and then worked with our clinical team to identify high quality cash providers. Janet chose a surgeon and had a consultation. We then agreed on a cash price for each provider who would be involved in Janet's care and secured approval from Janet's health plan. We then requested the funds in advance and paid each provider on the date of service. Because Janet's plan saved so much money on this procedure, her out-of-pocket cost was exactly zero compared to the almost $4,000 she paid for her left knee. And this is the power of cash payment for healthcare. Here's what we've been able to accomplish for self-funded employers to date. We've managed over 40 million in payments on the Medicash platform, handled 21,000 distinct cash transactions. We're reaching about 30,000 employee lives right now, and we've automated immediate payment of direct contracts. One way to kind of summarize this is through this results table, right? Asserta Health was created to make immediate cash payment work really for self-funded employers. We make it possible for consumers to pay cash for services using the employer's money, right? So that the members don't have to come up with all the money out of their own pocket and still have all of their payments applied to their deductible or out-of-pocket maximum, if they have to come out of pocket for some responsibility. As this table shows, we've averaged less than 140% of Medicare across thousands of cash transactions on behalf of our employer clients. Really, we achieve reference-based pricing like economics, but with substantially less friction because the provider is agreeing to a cash price. And our experience shows that immediate cash payment works for a broad range of healthcare services, not just big procedures like knee replacements, but also things like colonoscopy, sleep studies, even labor and delivery. What makes this possible is our proprietary payment platform, Medicash, and that platform leverages decades of experience managing healthcare payment for all stakeholders. It integrates cash payment seamlessly into an employer health plan and operates with the same sort of rigor that's used to process claims. We request funds from the plan and from the member when necessary, stage that money in our platform, and then we can pay providers when they deliver services. Medicash also captures all of the essential data about the services, and we can report a paid claim to the plan administrator. We couple our proprietary payment technology with a concierge service that guides plan members step by step through the process of selecting high-value providers and utilizing immediate cash payment to pay for care. Our combination of knowledgeable full-service customer service team, experienced negotiation and payment experts, as well as the effective utilization of federal laws and regulations, leads to a world-class member experience with high-value providers at dramatically reduced prices. And just to give you a little bit of insight into the evolving or changing regulatory environment that makes this possible, the Department of Health and Human Services has published a guide to your health information privacy rights that makes it clear that it's a patient's right to utilize their insurance or decide to pay cash. And additional guidance from CMS makes it clear that any individual who elects not to use their insurance is a self-paid patient. Now, we've been doing cash payment well before this regulation was in place, and it worked then, but this just makes it even more applicable to a broader range of geographies and services. There are several ways to deploy cash payment. Cash payment can be bolted on as an optional benefit to an existing PPO or reference-based pricing plan. And we do that with a large number of employers. But the real power of cash is realized by placing cash payment at the center of the plan. Plan members who choose cash options enjoy significant out-of-pocket savings, but the reference-based pricing or the PPO plan is always there as a backstop. Members engage with the concierge for guidance and choose which benefit to use prior to each service. We believe that cash payment is really the best way to maximize the value of most cost containment strategies, including direct primary care, which Scott referred to, direct contracts, and this even can be the foundation of community health plans. Just kind of want to quickly summarize by saying, again, the only way to make healthcare affordable is to pay for it the same way that we pay for everything else. direct, transparent, and immediate. I really appreciated Daryl's clip that he shared. To drive affordability, a real fundamental component of your strategy needs to be paying for care differently. And with that, I welcome any questions.
Corb, do you want to say anything about the LISA plan?
Sure. So the LISA plan is named after my co-founder, Dr. Lisa Benke. The acronym stands for Local, Intelligent, Simple, and Affordable. These cash-centric options are LISA plan options. So what we basically do in a LISA plan model is we remove the TPA as the kind of focal point of the plan, and Asserta Health becomes the plan program manager, for lack of a better term. And we coordinate all services with all the vendors. We also put ourselves in a position to take all member calls, all provider calls, even medical management runs through us. And what is the point of a LISA plan model? It is to maximize member engagement around cash payment opportunities. So, it really puts us in a position to identify as many services as possible, to pay cash. And what's the value in that? Well, again, we can be an optional bolt-on on a plan, but as this slide says at the top, that generally, we kind of max out at probably capturing 25% of eligible services in that model, where it's just an optional overlay on the plan or a bolt-on. When we have a cash-driven model, we have clients where more than 80% of their services are being managed on a cash basis.
Well, and Corb, share your pricing model, because I really respect the fact that you're not trying to take a piece of shared savings and kind of how you've priced it.
Sure. So whenever we successfully complete a case, we are paid a case fee. So it is a success fee. It's transactional in nature. It's tied to the reference price of the service that we pay. So our fee structure ranges from $250 for simple services like colonoscopies. Our maximum fee is $3,750 for things like open heart surgery. And so in a sense, we take a percentage of the savings, but we don't charge a percentage of savings because we think that really distorts incentives. And we believe that this is a fair price for the service. And and there have been many situations where we've saved $50,000 for an employer. Well, then they enjoy the bulk of that $50,000 savings.
And if you do the full plan, you just charge a PEPM, correct? And
that is correct. So when we're in the LISA plan model, where we're taking all member calls, all provider calls, and again, medical management runs through us. We're not a URAC accredited utilization management company, but we have a preferred partner. All of that's included in our PEPM in that situation.
Which is
$18 typically. It'll range a little bit on group size.
Okay, but if you don't have the medical management, it is $14. Is that right?
Correct.
Hey, Dr. Benke, did you want to say anything? Give you a chance to just kind of pitch in if you've got anything you want to share.
Sure. We've enjoyed sort of, we started out with a lot more knowledge about healthcare payment than most people we know. And we have learned so much more as we've been building the payment platform and using it. And we've just been amazed at the difference we've been able to make with just about any kind of service. We always knew that there would be a market for it in high cost services, but we can solve access issues. We can pay for complicated chemotherapy and radiation protocols. There's just no real limit to what we can do with cash when we have a provider who recognizes the value and a member who's willing to engage. And, that has led to the statistics Corb was sharing where, up to 80% of something going through a health plan, even emergencies. We have hospitals that are used to working with us and they get somebody admitted through an emergency and they call up and say, hey, we've got this plan member. We think that they work with you. Can you pay for this too?
Right. And even in that scenario, we're still averaging, again, under 140% of Medicare for those services.
Nice. I'm going to pitch in and say I had the opportunity. Corb took me on a demo of his platform last week, and I was blown away. I was very impressed with the comprehensive flexibility, customization. It's a pretty impressive platform. And Corbett, I don't know if you would be willing to let me share it, but if you are, I would be happy to share the recording with anyone who wants to send me an email and say, I'd love to see that. Corbett, would you be okay with that?
Yeah, that's fine. In general, we don't share our platform with employers. We do it more with partners.
Okay.
But for folks that are interested, I would just like to know who it's going to, honestly.
Okay. If you want to send me an email, I'll pass it by Corb, and then I'll send you the recording if you'd like. So yeah, I think John, you had a question.
No.
Steve Nielsen, I've got a question.
Go ahead, Steve.
Corb, Lisa, yeah, that very, very interesting and exciting what you've done here. Could you speak just for a moment or two? You talked about learning and all that you've learned about billing and paying and so forth. About the navigation portion, particularly in markets where you don't have a natural native presence, how's it going, and how do you learn, and how do you connect with the quality, make it happen providers in that marketplace, whether it's Idaho Falls or Austin, Texas? How do you do that?
Yeah, good question. And we're entering new markets all the time and performing cases in new geographies all the time. We generally start with quality. So we look at outcome-based quality metrics. We've worked with a number of partners, kind of through our experience. Some of it's, depended on also our clients' preference in terms of how they want to think about quality. But we will look at, typically we're more focused on surgeon quality. Obviously, both surgeons and facilities impact quality, but the outcome of a surgical procedure is much more dependent on the surgeon than it is the hospital. So we typically look at top tier surgeons, above average hospitals, and then that narrows kind of our selection range. And then we go about our cash pricing exercise. We do a lot of ad hoc pricing. We have a skilled pricing and cash negotiation team, and we will reach out to facilities. And in some cases, we're taking a great cash price that's just published. In other places, we're performing negotiations, and we're coupling that quality information plus that pricing information to steer to high quality options. The other thing that I should point out, though, Steve, is that our standard model is when individuals engage with us, we ask about their medical need, but we also ask about their preferences, and we generally try to accommodate those preferences. So one of the things that's different about us is, we're not a network company, we're not a network building company, and so we don't have an established network and say you have to go here. We work with people where they are and try to accommodate their preferences. Now, we can't always accommodate their preference. There are geographies that are more problematic, and there are certainly health systems that are more problematic, even on a cash basis. But we do attempt to accommodate their preferences.
So a follow-up question. Thank you for that. Good overview. Thank you. We purchased a list ourselves, probably been 5 or 6 years ago now, that included ranked all physicians in the state of Utah, and it was based on HEDIS and other data, Medicare and commercial information, but it didn't include outcomes. And so it sounds like I would imagine those kinds of databases are more robust, better now than they were 4 or 5 years ago, and probably you've taken that beyond just purchasing services and are able to engage in the local market in a way where provider to provider you can pick up on things. Is that kind of what if I had to try to summarize it in my own mind of what you do, is that how it works?
Yeah, I mean, we're believers that and by the way, unfortunately, quality is not a science in healthcare. That is just an unfortunate fact today. There is no established way of doing it. And by the way, I'm biased, obviously, but I believe the reason why quality is not a science is because of how we pay for healthcare. And if we paid for healthcare differently, it would become a science. Like transparent retail-like pricing will lead to, more established transparent quality as well, but they're going to move together. We believe that outcome information is the best quality information. So output is more important in our mind than inputs. And so we use outcome data wherever it's available, and it's not universally available. We use that wherever we can. Where we cannot use outcome data, we then gap fill with more traditional input sorts of means like procedural volumes, what am I looking for? Fellowships, et cetera, right? Those sorts of criteria. And then we certainly gain experience with providers and take that experience and feed it back, right? But, again, unfortunately, quality is not a science today.
Thank you. Thank you very much.
Anybody else have any questions?
I have a question, sort of.
Hey, Dave.
Hey. I don't know. Hey, Corb, it's good to see you again. It's been a long time.
Yeah.
I want to tell you guys a little story real quick, and I want to know if this is an issue with Asserta or if this ever occurs. My daughter, a month ago, was bruising very easily, and she was heavier menstrual period, 13-year-old daughter. So we took her to her DPC. They draw blood. The next day, they say, take her to the emergency room right away because her platelet counts were dangerously low. So we bring her to the emergency room, which I don't think was the right thing. The ER doctor doesn't know what to do, so he consults with a pediatric hematologist who says, take her home, don't let her get bumped or bruised or cut, and get her to a pediatric hematologist. So I knew what the diagnosis was. I spoke to a bunch of doctors, but bring her to the pediatric hematologist, and they diagnose her with something called ITP. So the first treatment they want to do is an infusion of IVIG, which is an immunoglobulin. And I say to them, I'm cash pay. I don't have insurance. So I said, what's the price going to be? And they said, well, $13,000, but you get a 50% discount. And I said, okay, of that $6,500, how much of that is the drug versus how much of that is the administration? And they said $410 is the administration, the rest is the drug. I said, great. I already priced it out. I can pick it up at the pharmacy for $2,300, so I'll just bring it in with me. And they're like, oh, no, we don't allow that. And I said, why not? Liability issues. I said, that's all BS, but how about I call the manufacturer, have it shipped right from there, and then you get it. And they're like, no, we don't allow that. And I really felt like the CEO of this large nonprofit hospital system had me over a barrel. Pay me $6,500, your daughter might die. So I agreed to do it. Well, her platelet counts returned to normal briefly and then plummeted again. Treatment number 2, an oral generic steroid for $3, which, by the way, is working much better. Now, here's the problem. And there's a clinical problem and a financial problem. I'm more interested in your feedback on the financial problem, but the clinical problem is that I've had a bunch of doctors send me peer-reviewed studies and a paper from the American Society of Hematology that said, based on my daughter's clinical state, the steroid should have been done first, not second. But the bigger problem is I got the bill today. It wasn't $13,000 with a 50% discount. It was $22,000 with a 50% discount.
So good news for you. Yes, I have good news for you. So any communication with you, and this is all part of the Consolidated Appropriations Act, any communication with you where you seek a price is called now by law a good faith estimate. They have to honor that good faith estimate within $400. That's the maximum deviation that they can make. And if they deviate from that, you just need to appeal it. And if you want to, shoot me an email, give me a call, Dave. We can talk about it. But they can't they cannot be more than $400 off of what they originally quoted you.
So that's how you solve the problem. If they wind up billing the patient afterwards, you have the good faith estimate, and you could say you can't do that. Okay,
that is correct.
Thank you. Excellent.
Yep.
Good question.
Yeah, this is one of the reasons why cash payment really should start to surge, because again, we've been doing it for years, long before the good faith estimate was in place, and we had a lot of success making cash prices stick because they're quoted, right? I mean, think of any other industry. Someone came to you and gave you a quote and then came back and said, oh, just kidding, it's 3 times that. Like, you know, that would never stand up in court. And it wouldn't stand up in healthcare really either, but you had to know how to fight it. Well, the Consolidated Appropriations Act makes fighting it easier. And all of the kind of procedures are on your side. So basically you get to dispute this. And when you dispute it, they can't send you the collections. They have to wait. And the point is they're going to be much better off just taking your payment for what they originally quoted.
Okay, thank you.
I had a quick comment, Steve again here. Another associate put me on to an article in Modern Healthcare back in October, and it speaks to the fact that it's an industry magazine. We all know that, and it's about telling hospitals about that their future is in cash payment. I was pretty amazed by that.
Yeah, I mean, both the major carriers and the hospitals in certain settings will acknowledge that the days of PPOs are numbered. Okay, they know that they're a scam. They know that they've been fleecing, you know, employers and really the public for years now. But while I think they know their days are numbered, for obvious reasons, they're going to hold on to what they have for as long as they possibly can. So they know that things are going to need to change. Again, obviously we're biased, but the way that it should go is cash payment, right? That's just what makes sense. There's absolutely no reason why price points should be hidden. And there's also absolutely no reason why providers should be in the financing business and that they should have to spend. I mean, there's a lot of recent information that says the percentage of revenue that they're spending, and it's as high as 1/3 of their revenue, is spent on collecting revenue. That's asinine, right? So cash payment really can be better for everyone, but it's also going to bring price points down. And those providers that are truly fleecing the public are going to have to make less, right? But so they're going to resist the change, but the change will come.
I could say something. Another thing that I think will really change things for hospitals, at least with our Medicash platform, is that we've also developed the ability to manage real-time immediate payment for low-cost services. So for physician office visits, for those hospital systems that own a bunch of physician practices, being able to, not submit a claim at all, be paid immediately on the day of service, without having to make phone calls, just using like an electronic super bill. We've done that with radiology. We can do it with any service where there's an agreement for pricing for particular procedures with very minimal effort on the part of the provider.
Yeah, I was going to maybe suggest, Corb and Lisa, that you describe how the provider engages with you in this transaction. I think that's very interesting as well.
Great, thank you, Scott. So, and there's really two distinct use cases that the bulk of healthcare services flow through, and the way that we engage with providers or that providers engage with us differ a bit in those two different use cases. So one is really a high cost use case. So the knee surgery example that we already used today, right? So, an individual needs a knee replacement. There's a facility involved, a surgeon, anesthesia, minimum. There might be other providers, right? In those situations, we are, the way we're engaging with providers is just pre-service. We know the details of the service that needs to be provided, and we are getting cash prices for those services. And again, in some cases we're accepting quoted prices. In other cases, we're negotiating those prices, but we understand, we understand how to appropriately price services. We understand the regulatory framework. So we have a lot of success, and we try and make it as easy as possible on the providers. So that's typically, how that's managed. We then pay those providers however they would like to be paid. We can pay them electronically through our platform. We can also pay them via corporate credit cards or check. Really, it's up to them. So we can pay them however they would like for those high cost services. For lower cost services, and Lisa also already alluded to this, we have the ability for providers to log into a portal that we've created where they can see all of the payment history, but where they can also report services. And so we have a pre-agreed upon super bill, and basically a super bill is just a list of codes and the prices that have been agreed upon for those codes. And so they enter just a real bare minimum of information. They can search for patients that are on our system. They enter a bare minimum of information and then select the codes that represent the services that they've delivered, and then they can be paid immediately. And so it really streamlines administration and payment for them.
Good point. Thanks for bringing that up. Scott, any other questions?
Oh, I wanted to add in a question about J codes, if that's okay.
Sure.
Okay.
I really just that. Any success with J codes? Context for the question. Got a client with a 1.2 million annually recurring J code that's not going anywhere ever. Wanted to ask about that.
I have solutions for that, Jeremy.
Yeah, we've chatted about it. Yep.
We
Yeah,
can help with that, definitely.
so Lisa, you want to speak to that too, but we have had success.
We have had a lot of success with, because as long as you agree on the price for the J code. Now, if there are some very expensive drugs out there that, are just not, the only way to deal with them is not to cover them. But for chemotherapy, for, any drug that is part of a regimen or a regular, we've had a few cases where we have somebody getting an infusion once a month forever, and we handle that through the platform seamlessly as well.
Yeah, I heard that, maybe Johnny, you were the one to tell me this, but the FDA just approved a $2 million drug per dose.
3.5 is last headline I saw.
3.5 million.
Yeah, I mean, there are, to Lisa's point, there are certain things
with everything.
Yeah, that the only way to handle them is to not cover them, and I'm sure that's probably what Dave was referring to in terms of solutions. There are programs where you just don't cover specialty drugs, and then you use the patient assistance programs. But yeah, and we actually are in a position to help employers with that as well. In fact, we think the rates that the average PBMs are charging for these types of services are absurd. Like some are charging 30% of savings, 20% of savings. If you want something that's more reasonable, we'd be happy to talk with you about that as well. But for things that are in fact covered, right, where they're covered under your plan, you haven't excluded a specialty drug, and where you're just getting kind of fleeced by certain providers, having people be cash pay can address some of those scenarios. Moving the place of service and direct shipping drugs is another thing that we've done quite successfully on a repeated basis.
Yeah, and we have a lot of international sources for those types of drugs, even cold chain stuff we can get typically. So if the manufacturer's program isn't available because of income or whatever, we have other solutions too.
Corbin and I had a great conversation today about the whole concierge navigators and not just reminding people that you have this service and hoping that they remember when it comes time to using it. And clearly avoiding all deductibles is a great incentive. But as you all know, and have heard me say many times, the key to following the best healthcare system in the world is to build relationships into the healthcare system. And when you build a relationship with every employee, or you at least create the system whereby employees can create those relationships up front, not when there's an event, but literally during the enrollment process, that trusting relationship becomes critical in engaging and making sure that everyone is using those cash pay strategies when things come up. So again, the aspirational healthcare model is we want them to have a partner that's a medical partner, a navigator partner, and a coach partner, someone that's going to help them live life to its fullest, someone who's going to help them navigate the healthcare system, and someone who's going to actually coordinate their care at all levels. When those relationships are built with each member of the plan up front, and yes, there's no question, that's expensive. That's going to be a whole system that most plans have never thought about or heard, but the savings in putting that relationship up front and engaging a lion's share of the people to use these strategies is the key to making sure that they get used. They get used. And Corbin and I have had a great conversation about, he's got these care navigators, or these concierge navigators, that what you call them, Corp, that could very easily be set up to create those relationships up front. Obviously, there's going to have to be some pricing analysis to determine what that's going to look like. But think in terms of upfront prevention and relationship, not just, oh, I hope they remember because of the incentive, that the benefit is there. Other questions?
Corb, it might also be helpful to talk about the resistance that we've heard from, some employers that, well, our PPO contract doesn't allow us to do this type of transaction. Can you talk around how we address that and how that's been addressed and basically overcome in the marketplace?
Yeah, and really we like the payment model is pretty critical for navigating this this potential objection. So we are doing this with we're not doing it with, I want to be clear, we're not doing it with BUCAs, but we are doing it with BUCA-owned TPAs and their networks, and obviously they know it's happening. So the reason why we're not running afoul is the payment model is fundamentally different. They're not submitting a claim and getting paid according to a managed care agreement. We are paying cash prices that are mutually agreed upon. We're not running afoul of PPO networks because of the different payment model. Now, some have said, if we hear noise, we'll start to push back. The good news is there is no noise. We're paying providers a cash price that's mutually agreed upon. And so there's really been very limited noise associated with the strategy.
Corb, you helped me understand the difference between cash pay strategy and self-pay strategy. Do you want to address that?
Well, I mean, they're really kind of synonyms for each other at this point, especially given the Consolidated Appropriations Act. So any individual at their legal discretion can be cash pay or self-pay. And the law is crystal clear. It's just anybody who chooses that they want to pay cash for a service becomes self-pay. That's the legal definition of it. And so at this point, there really are synonyms. There are some legal things that we don't want to run afoul of. So technically, to operate this, to be completely compliant, a self-pay individual should not get funds from their health plan that's set up, to pay the expenses through the PPO or for that matter, even for the reference-based pricing plan. Technically, there should be a separate legal vehicle set up. It's still funded by the employer, right? I mean, ultimately, the money's coming from the same place, but the right legal structure is to set up an alternative plan where these sorts of payments are coming from. But in that sort of structure, it's fine, right? It's, they're self-pay. The employer is funding their self-pay status, but it is, it's well protected and legal.
Nice. Anybody else have any questions? We've got just another 10 minutes.
Corb, I don't know if I still have your email address, but I think we need to talk because, we're not doing any PPO plans at all. 100% of our book is non-PPO, non-BUCA. And most of our plans have direct primary care involved. And what I am thinking is that you could not only be a resource for the members who are not on the DPC plan, but you could also be a resource for the DPCs.
Correct. In fact, Scott has helped put us in touch with the direct primary care practice in Idaho. And by the way, I think this should be the future of direct primary care. I mean, direct primary care is great at controlling utilization, but once utilization leaves their clinic, they lose control. This, Scott's done a good job of convincing them of you should own the contracts. You should control the price points. And we can facilitate that. Our platform is set up in a way that we can facilitate that. And there's concierge services that are needed, we can provide services. So we can provide technology, we can provide services, we can provide both. It's really a function of what folks need. So be very interested. I'm sure I can dig up your email and reconnect with you.
Yep. Okay. Yeah. Because 100% of our plans have out-of-pocket waivers for manufacturing programs on drugs, international sourcing, and then when we do a cash pay or direct contract.
Yeah. No, would love to reconnect and talk about it.
Great questions. Anybody else have a comment or question, or even just a thought?
Way to go.
An open enrollment meeting to do for an Alaska company that we just wrote in 9 minutes. So I'm going to go get ready for that and then be done for the weekend.
Good luck.
Thanks, guys. Good to see everybody.
It may be in closing then, before everybody jumps off, let me just mention that we've had so much success with this idea of creating an aspirational healthcare advisors group. We're starting up 3 other groups. One will be an aspirational healthcare employers group. If you've got any employers that you think would be helpful for them to join a brainstorm with other patient-centric employers who want to build healthcare around the patient, just let me know. Our first meeting is going to be January 6th at noon Mountain Time, and I'm going to have Corb introduce this cash pay strategy as one of the very first things that we do with the employer groups. We've already got a number of employers that are interested in participating. If you've got any employers that you think would be valuable or you'd like them to hear this, let me know and we'll send them an invitation. We're also creating an aspirational healthcare systems group. NUCA has agreed to kind of be the anchor member of that group. We've got other healthcare systems that have helped us with our conference that are also going to be joining. But it's really about taking the most innovative healthcare systems and having them learn from NUCA how to move the entire healthcare system towards an aspirational model. So we don't have a date scheduled for the first one. That'll be another group. And then we have another group that we're going to be starting up that'll be the aspirational healthcare providers group. So anybody that's in a provider space to help us build the ecosystem around this aspirational model would be welcome to join that group and figure out how we can work best together to serve both you and employers in this aspirational model, which is really just healthcare built around the customer. Anybody have any questions about those groups? We don't have a date for the systems or the providers, but we'll be starting that up here in the first quarter of next year, where we'll be doing something very similar to what we've done with the advisors. And the hope would be that we can create synergy between all 4 groups and learn from each other, and again, brainstorm and push this industry in a better direction to be more customer-centric. All right, anybody have any questions about that? One last thing I'll mention is that my company, Orion, has just signed a contract with Nice Healthcare to create a combined both virtual come to your home direct primary care solution that's also accompanied by coaching, helping people live life to its fullest. And that's a B2C. We're going to be selling that not to employers, not to people who are already covered by our health plan, but to people who are underinsured or who don't merit benefits because they might be just part-time. So anybody that's interested in learning more about that, that's under orionlife.com. And again, Nice Healthcare, which is that unique DPC that comes to your home, and us are partnering to create that solution together with coaching and very customer-centric primary care. Anybody have any questions about that? All right, well, let me thank Corb and his team. It's very nice to meet you, Dr. Benke. It's good to see you again, Nicole. And look forward to working together. And thanks everybody for joining.
Thank you, Daryl. Pleasure to meet you. Bye-bye.
We'll see you.